Today we will start discussing the pediatric physical examination. This is part 1 about general appearance, vital sign, and anthropometry. General appearance contains three major components. From this, the first one is appearance. In appearance, sometimes correct diagnosis can be reached by a simple observation while taking history. General mental development can be assessed from the activities and also speech of the patient while the mother is giving history. Specific diagnosis can be made from inspection of the face in some cases. For example, in Down syndrome, you can see a flat facial profile, depressed nasal bridge, lossy teeth, epicanthial fold, and the like. So any dysmorphic feature should be seen, whether they are present or not. And also we should have to see whether the child is sick looking or acutely sick looking or chronically sick looking or well looking. If the child is acutely sick looking, we should have to check whether the child is in cardiorespiratory distress or not. And also, the state of the nutrition of the child should be seen from general appearance. So, is the child grossly wasted or grossly emaciated, or is the child overweight or obese grossly? So, state of nutrition can be assessed from the general appearance. When we come to the second part of the general condition examination, state of wakefulness is the other component. Level of consciousness goes down from normal to the stage of coma. Normal, confusion, lethargy, obtundation, stupor, and the coma. This is steps of wakefulness or steps of consciousness. When we define each of the components of wakefulness, alert is normal awake and a responsive state. This alert is a quiet condition at which a child is normally awake and responsive to external stimulus. Lethargy is easily aroused with mild steam and it can maintain arousal, whereas somnolent is easily aroused by voice or touch, awakens and follows commands and require continuous stimulation to maintain arousal. When we go to obtunded or stuporous, this is arousable only with repeated and painful stimulation, and the verbal output is unintelligible or nil, and some purposeful movements to noxious stimulation can be seen. Comatose is the condition at which the child is in no arousal despite vigorous steam, no purposeful movement, and only posturing or brainstem reflexes often absent or present, and the respiration may be varying. So this is the level of consciousness and how we define them. The other is color. There are three components of color that we see on the general appearance. Those are paleness. Paleness can be seen on palm of the child or from the tongue or lips. We should have to compare with the hands of the mother to check palmar pallor, and also palmar pallor can be graded based on whether it involves the palmar craze or not. If it involves the palmar craze, it is severe palmar pallor. The other is cyanosis. Cyanosis is a condition at which low oxygen levels in the blood causes the lips, fingers, and the toes to look blue, or this is called cyanosis. So bluish appearance of the lips, fingers, and the toes can be seen on the general appearance. The other components of color examination general appearance is jaundice. You can see on gross jaundice, or you can see ecteric sclera on general appearance. The other parts of deeply examining the cyanosis, pallor, or jaundice in the other parts of the body is seen in the systemic examination. This one is on the general appearance of the patient. The other thing that we will going to discuss today is about vital sign. Vital sign contains from the different vital sign components. The first one is temperature. Rectal temperature is preferred in infantis. In taking rectal temperature, the patient should lie on the lap of the mother with the chest and the abdomen, and do not put in rectal thermometer with the patient laying in the supine position. When we do rectal temperature examination, the bulb of the thermometer should be inserted 2 cm into the anal canal and keep the thermometer for about 3 minutes. And the other place that we can check a temperature is oral temperature. And oral temperature should not be taken in infants and young children. In older children, the thermometer should be put under the tongue with the mouth closed, And oral temperature should not be taken if hot or cold drinks or food has been taken a short while ago. And also in children, auxiliary or growing temperature can also be taken. Most of the time we take auxiliary temperature in our setup. Oral temperature is lower than rectal temperature by 0.2 to 0.5 degrees Celsius, and auxiliary temperature is lower than oral temperature by 0.5 degrees Celsius. And that means auxiliary temperature is lower than rectal temperature by up to 1 degree Celsius. And also, since there is a diurnal variation in the body temperature, the time of measurement should be noted. So the time at which we take the temperature and also the place from which we take the temperature should be documented. In rectal or oral temperature measurement, a thermometer should not be shared among patients to prevent transmission of disease. So if we use the thermometer to measure rectal or oral temperature, it should be used for only a single patient. And the temperature is measured in degrees centigrade or Fahrenheit, and it is important that the examiner be able to convert the reading of his desired method. For example, if you took by degree Fahrenheit, you can convert it to degree Celsius by this formula. Degree Celsius is equal to Fahrenheit minus 32 times 5/9. And if you took by Celsius and you want to convert to degree Fahrenheit, you multiply the degree Celsius of temperature measurement times 9 divided by 5 plus 32. The other component of vital sign is pulse. In a young infantis, neonates, apical heart rate is preferable, whereas in other age groups, peripheral pulses can be taken. When we measure the pulse, the rate, the rhythm, and the volume of the pulse should be noted. Don't forget the rate, rhythm, and the volume of the pulse. Number, regular, and also the volume. Is that full in volume? Is that weak? And also we should have to describe the rate, rhythm, and the volume of the pulse when we take peripheral pulses. And interpretation of the count depends on the average counts in the various age groups based on the age of the child. The other component is respiratory rate. As breathing pattern is not regular in children, the rate should be counted for full 1 minute. And the patient should be made as calm as possible. In addition to the count, the pattern of breathing should be noted also. The other component of vital sign is blood pressure. In measuring blood pressure, select an appropriate cuff size. So cuff size is very important, because narrow cuff give you higher reading while wider one give you lower reading. So the cuff should cover not less than half and not more than 2/3 of the arm. And also to estimate the systolic blood pressure, the cuff should be inflated first, then slowly deflate the cuff while the other hand fingers are put on the radial artery, and the point where the first radial pulse is felt indicates systolic blood pressure. Then the exact systolic blood pressure can be determined by auscultatory method by identifying the point at which the first sound is heard while the cuff is slowly deflated. In children, the fourth Krotkov sound is the accurate measurement of diastolic blood pressure, because in adults we use the fifth Krotkov sound as a diastolic blood pressure, and in children we use the fourth Krotkov sound because the fifth Krotkov sound underestimates the diastolic blood pressure in children. When the sounds are not well heard, augmentation can be done by raising the arm above the head, then inflate the cuff, and then lower the arm, and then take blood pressure. Flash method can be used to measure blood pressure in infantis. That means apply the cuff on the lower leg, compress the foot by hand and inflate, and then deflate slowly, noting as the flash returns, and the blood pressure returned by this method is slightly lower than the systolic blood pressure. Blood pressure is routinely measured on one of the arms. However, in some cases, such as in the case of coarctation of aorta, if the patient is hypertensive, or if we suspected Takayasu syndrome, it should be measured in both upper and lower extremities, and the value should then be checked against the curves for age. The pulse pressure is 20 to 50 mm of mercury in children, and after infancy, the systolic blood pressure in the arms is 10 to 20 mm of mercury higher than in the legs. On the other hand, the diastolic is the same in both the arms and the legs. So always in the normal condition, blood pressure in the arm is 10 to 20 mm of mercury higher in the arms than in the legs, the systolic one, whereas the diastolic one is the same. During inspiration, both the systolic and the diastolic blood pressure decrease due to pooling of blood in the pulmonary bed. However, the drop could be exaggerated in constrictive pericarditis or in severe asthma. This phenomenon is called pulsus paradoxus. The other thing that we should have to talk today is about anthropometry. Pattern of growth should be followed rather than a single measurement in the assessment of growth, and a significant deviation from the pattern followed by a child should be alert the clinician to consider an underlying serious condition. From different components of anthropometry, the first one is weight. Weight, it is the most important measurement in pediatrics because diagnosis, treatment, and also progress of the patients are based on weight, and the serial weight measurement is more informative than a single measurement to assess growth. Take weight using a weight scale that has been checked for its accuracy, and also prior to taking weight, make sure that the scale reaches 0 when in PT. Weight is taken with a child naked or with a light clothes on it. The other components of anthropometry is height or length. Height, to take the length in recumbent position until 2 years of age. The difference is length is taken in the recumbent position, as you see on the image, until 2 years of age, because they can't support to stand or they can't able to stand to measure the length. To measure the height, sorry. The procedure requires 2 persons, a measurer and an assistant, to measure the length of the patient. Patient lies supine, flat and straight in the recumbent position on a board. The assistant should put the head to touch firmly the fixed headboard, and the measurer pulls the legs gently, putting one hand on the thigh to put the knees straight. The measurer then moves the feet board so that it is brought to touch the soles of feet firmly. So this is how we measure length in a recumbent position until 2 years of age. When we see the measurement of the height, in those above 2 years of age, standing height is taken, and the reference points for appropriate posture to measure the height are: stand with the feet together, the occiput, the shoulder, the buttock, back of calf, and the heels touch the walls or the measuring apparatus. Then the angles of the eyes should be parallel to the floor. The other components of anthropometry is head circumference measurement. The head grows rapidly during the first 2 years of life, and the size of the head is related with the growth of the brain tissue. Therefore, measurements of the head offers an estimation of the rate of brain growth. It is measured by passing a tape over the most prominent part of the occiput and just above the supraorbital ridge. The value for each of the above anthropometric measurements should be compared using the standard growth charts. When we see the other components of anthropometry, MUAC is another thing. Mid-upper arm circumference. This is useful for fast screening purpose in the community. In the under 5 children, the circumference is almost the mid-upper arm circumference is almost constant. It is measured using a flexible tape and identifying the midpoint of the arm between the acromion and the olecranon. So we should have to make sure that we are measuring between the midpoint at which acromion and the olecranon meets. The arm should be hanging freely by the side of the body and it should not be flexed. We say it's normal if it is greater than 12.5 centimeter. If it is between 11.5 to 12.5 centimeter, we say moderate acute malnutrition, and if it is less than 11.5, we say severe acute malnutrition. The other components of anthropometric measurements are chest circumference, and the other components are crown heel and crown rump length. Chest circumference is measured at the level of the nipples anteriorly and the inferior angles of the scapula posteriorly, and at around 8 months of age, the ratio of head to chest circumference is 1 to 1. This is a crown heel, crown rump length ratio, and at birth the trunk is longer than the limbs. So the trunks are longer than the limbs, and it's not the ratio is not equal. The ratio becomes equal at around 7 years of age. At birth it is around 1.7 to 1, whereas at 4 years it's around 1.4 to 1, and at 7 years it's around 1 to 1. So when we interpret this anthropometric values based on the age and the gender of the child, there are 5 standard gender-specific charts that we should have to interpret on the WHO growth curves for children. Those are weight for age, height for age if they are greater than 2 years, and the length for age if they are less than 2 years, head circumference for age, weight for height, or weight for length if they are less than 2 years of age, and also body mass index for age. So by interpreting this on WHO growth curve for each specific age and the gender, we can interpret the nutritional status of the child. Thank you. Subscribe this channel for further additional physical examination discussion on pediatrics.